Good morning, one and everybody. Thank you, Dr. Ganesh, for a kind invitation. I'm extremely sorry. I may not be able to do personally this talk at Mangalore. That's why I'm sending the Zoom recording of the talk. Thank you for accommodating this request. So surgical fitness for a diabetic patient is very important because now and then we get requests from the surgical colleagues for the fitness of a surgery for a diabetic patient. We know that diabetes is a worldwide disorder. Diabetes patient may need a surgery more often than the non-diabetic patients. And whether it's a known or unknown diabetes, means diabetes detected first time on admissions increases the perioperative risk. Hence, diabetes patients should be given a special attention before, during, even after surgery. Diabetes patients follow what is known as a Rule 25. That is 25% of the patients undergoing surgery have a hyperglycemia, maybe newly diagnosed or stress hyperglycemia or known diabetic. Around 25% of the diabetes undergo surgeries. Overall, if there are 100 diabetic patients are there, 25 patients, they require surgery one or other time during their lifetime. 25% of a hyperglycemic patient perioperatively have a stress hyperglycemia and subsequent evaluation may be normal. And 90% of the patients undergoing cardiac surgeries are a diabetic. That tells the burden of a heart disease in a patient with diabetes. And hyperglycemia is an independent mortality predictor when it comes to the in-hospital admission, even during a surgery. So the diabetics are termed a high risk in general because they expect a lot of acute complication in the form of a hypo or a hyperglycemia, fluctuation in the sugars, highs and lows, and also associated water and electrolyte disturbances. Chronic hyperglycemia does alter the body homeostasis and makes them prone for a complication during the surgeries. Diabetes have a worse surgical outcome compared to the non-diabetic. It increases the hospitalization, duration of a stay in the hospital, poor wound healing, and also recovery from the illness longer than the non-diabetic patient. These are some of the things which is expected in a patient with a diabetic. Patients of the diabetes are prone for a silent MI. They may be perfectly fine, but they experience what is known as silent MI. That's why the anesthetists are worried. They have got an accelerated atherosclerotic cardiovascular disease. Their effort intolerance is less compared to the normal person. They are prone for a diabetic gastropathy, means gastroparesis is there. Even if the drug is given, the absorption may not be ideal. And also, this leads to lots of anesthetic complication and intubation complication. Because of a hyperglycemia, there will be cellular dysfunction and killing of the bacteria and the other infections. Hence, there is more prone for a infection, and this is very well seen when glucose is more than 200 mg/cent. So even an acute disturbance in the glucose levels, what we call it as acute dysglycemia, increases the counter-regulatory hormones like cortisol, glucagon, all these things. Stress increases the glucose level in otherwise somebody who is not known a diabetic. The cytokines released during a surgery does produce acute insulin resistance and increase in the glucose levels. And stress hyperglycemia was special category wherein the first time they'll be presented more than 140 or 180 based on the studies you are including. Previously, the normal HbA1c is normal. Only the current glucose levels will be on the higher level. This is known as the stress hyperglycemia. They are more prone for a complication than the non-diabetic because the first time they're experiencing the hyperglycemias. Surgical stress, the admission increases the counter-regulatory hormones. This counter-regulatory hormones causes lipolysis from the adipose tissue and also reduces the insulin secretion from the pancreas. There is insulin resistance at liver, at skeletal muscle, and also at the insulin action sites. All these things leads to the hyperglycemia. This hyperglycemia produces superoxide the generation and insulin resistance further worsens. Immune dysregulation happens, endothelial dysfunction happens, and a mitochondrial injury happens. Hence, patients with the hyperglycemia, whether known or unknown diabetes, have complications. That's why assessment becomes more important before surgery. What is the type of a diabetes is an important, how well they are followed up, whether they are on insulin or oral medication. If they are on insulin, how much dose they are taking, what insulin they are taking, how good is their technique and compliance, and also based on their clinical examination, how sensitive they are, whether they are insulin resistance or they are insulin sensitivity normal or a more insulin sensitivity prone, that needs to be assessed. Adequacy of a control, anything less than 8.5 should be okay. Up to 9, some guidelines do say it's all right. Whether it's an elective surgery or an emergency surgery, because we need to decide the interval of a surgery and what is the anticipated time of a fasting or a NPO before they are taken up for a surgery. So the best thing to follow is this color graph. If HbA1c is between 6 to 8, by and large, that's the best time to give a fitness for a surgery. So this can be little extended when somebody has got a HbA1c of a lower limit of a 5 and upper limit up to 8.5 or a 9. So best thing is 6 to 8. The other best thing will be between 5 to 8. Below 5, those who have got recurrent hypoglycemias are also having sometimes the lower HbA1cs, and also they'll be people who are above 8.59 also have got a lot of immune dysregulation when it comes to the phagocytic killing. Type of a surgery is also has got an impact on the outcome. What is anatomic location of a surgery? What is the invasiveness, whether it's a open or a laparoscopic. It has been found that surgeries involving thorax and the abdomen are associated with a more pronounced and a prolonged duration of a hyperglycemia. Patients who are undergoing laparoscopic procedures demonstrate decreased incidence of insulin resistance, lesser degree of hyperglycemia. This also matters when it comes to the giving a fitness. So we need to carry out certain bedside evaluation, simple bedside test to know the cardiac autonomic neuropathy, because it's one of the most important thing anesthetists should know, because this can lead to a sudden death on table. What is the respiratory variation happens with the heart rate, whether it's a fixed heart rate, resting tachycardia is there or not, whether there is orthostatic hypotension, and whether patient in the hospital, if you have got a facility for a 24 hours blood pressure monitoring, is there any nocturnal dip happens or not. These are all the important bedside evaluation we need to do before we give a fitness. So the minimum assessment involves based on the patient's examination, what is the BP, supine and the standing, the ECG at rest, and the urine test for even the protein, even the glucose, and what is the creatinine levels. If patient has got a suspected gastroparesis is there, look for a bloating, succussion splash can be elicited. If patient has got suspected cardiovascular disease, whether it's a symptomatic or a asymptomatic, if patient is a symptomatic, we can make out with history, even the ECG. Sometimes patient symptoms will dictate the further investigation. Asymptomatic, check by the person's blood pressure, what is the creatinine value. If possible, non-invasive test like a coronary calcium score can be done. Even a proteinuria indicates parallel damage to the heart. Cardiac autonomic neuropathy test can be carried out at the bedside. That will further tell about the patient's cardiac fitness. There is one criteria known as a revised cardiac risk index, RCRI. This is proposed by the Lee. This is also known as a Lee index. So this is one way of assessing preoperatively. If patient has got a CV or a TIA, you give a 1 score. Diabetes, which is requiring a insulin, 1 score. Creatinine more than 2, 1 score. History of coronary artery disease, 1 score. Any high risk surgery like involving abdomen, thorax, fine. Any vascular surgery like a CABG, score of a 1. If the score is less than 1, the risk is less. If it is more than 1, less than 3, it is a moderate risk. More than 3, it is a high risk. Based on this, we can convey to the anesthetist, probably is the high risk, we need to look into more carefully during the surgery. Anesthesia, most anesthetic agents cause a hyperglycemia, and IV induction agents have a minimal effect on the blood glucose level rather than inhalatory. Excuse me. There are certain exceptions to this rule, like halothane inhibits insulin production. Etomidate blocks the 11-beta hydroxylase. We know that is one of the treatment used in the hypercortisolemia, does produce adrenal insufficiency. And benzodiazepines reduce ACTH secretion, reduce the sympathetic stimulation. Opiates, sympathetic block produces, abolishes the hyperglycemic response. Epidural blocks the catecholamine. This one way or other interfere with the glucose metabolism. Nutrition is the most important. Most diabetic, when I say is a type 2 diabetic patient, tolerate fasting. without major complication. Fasting means they can tolerate missing of a one meal. Fine. But we should avoid this prolonged fasting. And also there is one study known as a enhanced recovery after surgery program advocates carbohydrate rich drinks up to 2 hours before surgery to avoid catabolic state associated with the starvation. This is only done if patient has got a no gastroparesis or any other cardiovascular autonomic neuropathic symptoms. Glycemic targets are very well defined. Recommended during surgery perioperatively is anywhere between 140 to 180. Lower limit even 110 is good enough, but never to cross 180. In some studies, even up to 200 has been shown. HbA1c target 8.5 is a good target. Anything less than that should be good enough. Acute glycemia, we know that by the daily routine glucose monitoring. Chronic control will be reflected by the A1C. Both are important. Even HbA1c is important. Even the current glucose levels are also important. When the HbA1c is more than 8.5 and you want to do a immediate surgery, that time current glucose levels becomes more and more important. We need to target the current glucose levels. For emergency surgery, by and large, there is no proper evidence-based guidelines are there. There is one recommendation which has come from the American group, that's the Yale New Haven Hospital. They are told that anything less than 400 in an emergency, you can give a clearance, but avoid compromised metabolic states like a DK and a HSS. Other than that, blood glucose levels less than 400 in an emergency setting where life is more important than the surgery, you can give a clearance for a surgery. Medications, I think insulin is the ideal in a perioperative setting, especially if they are going to stay for more than 2 days involving the abdomen or a thoracic, and with a regular monitoring, basal bolus regime is the most preferred. Long-acting insulin for a basal requirement, up to 50% of the total dose can be given, and 80% can be given on the day prior. And when patient is fasting, it's only a basal insulin which is good enough, no need to give a bolus. And short-acting insulins associated with the meal we need to give can be omitted on the day of a surgery, and it can be reduced after a first meal. Premix insulin, if somebody is very well controlled, want to undergo a surgery, that time we have to give a reduced dosage. This reduction can be to the tune of 50%. Insulin infusions are preferred when person has got a type 1 diabetes, recurrent hypo and hyper to maintain a euglycemia. Insulin infusions are preferred. Patient who is at the DK and HHS has got a acute emergency, yes, we need to give an insulin infusion. Prolonged nil orally, especially certain abdominal surgeries, probably insulin infusion is better than the subcutaneous. And during labor, especially GDM patients and all, we need to give a insulin infusion. OHS, among all the OHS, safest OHA is a DPP4 inhibitors. These are preferred perioperatively. Metformin can be ideally continued, has to be skipped on the previous day. Sulfonylureas, hypoglycemia risk is there. By and large, stop it unless patient is very stable sugar and undergoing a minor surgery. Pioglitazone, stop it in a high-risk elective surgeries. SGLT2 inhibitor has to be stopped 3 days prior to surgery to reduce the risk of a euglycemic DKA. Targets, same intraoperative, anywhere between 100 to 150, not to cross 180. Early enteral feeding should be discouraged. Hypoglycemia, anything less than 70 or 72 is a hypoglycemia. Whenever person gets to this glucose level, we need to follow what is known as a rule of 15 grams of a carbohydrate, quick carbohydrates in the form of a glucose tablets or a juice or even a dextrose can be given, and this can be repeated for 3 cycles till it crosses the 72. The best practice, what to do during preoperative evaluation of a diabetic patient is timing of a surgery has to be determined, weighing the risks and the benefits of the procedure, and also optimize the glucose level. Surgery needs to be kept on the earlier part of the day, preferably the first surgery. If there are non-diabetic patients are there, diabetic patient needs to be taken first. Ensure that all the old medications, whatever he has taken, should not be stopped suddenly, otherwise you will encounter a sudden hyperglycemia. Proper care plan has to be written and it needs to be continued preoperatively. Even peri and post-operatively, and we need to inform which medicine needs to be stopped to the ward nurse or a surgeon or an intern who is taking care of it. And also we need to look into hypoglycemia also. Not only hyperglycemia important, even hypoglycemia is equally important when it comes to the managing bedside. To conclude, diabetes is one of the most common comorbidities what we see and what we clear for a surgery. Thorough preoperative evaluation is essential, looking into all the angles what I have stressed. Clinicians should adhere to the local guidelines or whatever the society we are prescribing the guidelines, and these guidelines needs to be updated frequently so that we can give a optimal care. This is my last slide. Thank you for your patient hearing. I end my presentation here.
We now move on to the next session. We now call upon our speaker, Dr. Matthew John, to talk on de-escalating anti-diabetic medications.
Good morning. We are now moving to the next session, de-escalating the anti-diabetic medications. As we are all aware, de-escalation is an important part in the treatment of diabetes. As it is escalation and de-escalation both play a major role in the treatment and control of diabetes. To throw light on this topic, I request Dr. Matthew John to take this session. He is endocrinologist at Providence Endocrine Diabetes Specialty Center, Trivandrum. And he has over 50 publications in index journals and 30 conference presentations. He was the past secretary of PACE and ESI Kerala chapter. With this introduction, I hand over the stage to Dr. Matthew John.
Thank you, sir. Thank you, Ganesh and Krishna, and for inviting me here, Sudeep. So, my topic is regarding de-escalating anti-diabetes medicines. Sorry. So, obviously, there is no conflict of interest unless you are increasing the medicines. So, here, this is a data set which is very familiar to everyone. It looks at glycemic control and diabetes complications. So, whether you look at type 1 diabetes as shown by the DCCT trial or type 2 diabetes as shown by the UK PDS trial, glycemic control can reduce diabetes complications. There is no doubt about that. So, traditionally, we have been following treat to target. So, basically, what is treat to target is the current concept that we follow in glycemic management, where we keep on increasing the medicines or insulin to achieve certain targets of glucose control, like say reaching a fasting less than 100 milligram per deciliter, or over 3 months trying to reach an A1C less than 6.5%. This is what we really do in clinical practice. And the advantage of treating to target is that without bias, we are able to adjust the dose of medicine so that the patients reach glycemic control. So once the patient reaches glycemic control, then we can compare between drugs. So whether this drug produces more hypoglycemia at a same A1C, or it produces a weight gain, etc. So treat to target is what has been proposed all the way, even in whatever guidelines that you take. But we have a risk of over-treatment in diabetes. There is no real definition of what over-treatment is, but if the potential harms of a treatment exceeds the benefit, it can be considered as over-treatment. And for a particular patient sitting in front of you, it's a bit difficult to judge whether you are really over-treating that patient or whether you are just treating the patient to target. Because in an elderly patient, a hypoglycemic can be more risky than putting the patient at an A1C of 8 or 8.5. When you treat hyperglycemia, why you are treating hyperglycemia is to prevent microvascular complications predominantly. And if the patient is not going to live for 5 or 6 years, it's very unlikely that treating aggressively will produce any benefits for that patient. But at the same time, we don't know whether the patient is going to live for a further time like 10 years. But if you put your life into an expectancy calculator, sometimes you can see that 88, 90 is what we reach for most of us who are here. So that's very difficult to judge this. But it's always important that if you have a simpler regime, you can use it instead of a very complex regime. Now, what is de-escalation of treatment? So basically, it is reducing the intensity of treatment. Again, there is no clear definition for this in literature. It could be reducing the drugs or stopping the drugs, reducing the frequency of drugs from 3 or using EGFR, which may lead on to a change in your therapy, like metformin you would like to stop or withdraw, or a new onset heart failure where you like to stop a pioglitazone, things like that. A treatment failure obviously is a reason to withdraw a drug. Suppose the patient is not responding to sulfonylureas, you would like to withdraw it. Elderly patient where life expectancy is less, again. Certain patients, due to certain reasons, you can prefer a less intensive regime. Tolerability can be there. Someone is not tolerating a GLP-1 you can stop it. Frailty and low level of support, low cognitive function, and short life expectancy. So these are various indications for de-escalation. There is another word called de-prescribing. I went through literature, but I could not really understand this. These are two different things because different articles use de-prescribing and de-escalation in different ways. But de-prescribing has got a definition in one of the articles saying that it is a planned and supervised process of dose reduction or discontinuation of medicine. So I think this may be the same thing as de-escalation, but I really don't know. And to improve the patient's quality of life and reduce the number of medicines. So I'll just go through 3 or 4 cases to demonstrate what I'm trying to convey. So this is a 78-year-old lady, type 2 diabetes for 14 years. She's on metformin, glimepiride, atorvastatin, telmisartan. And she's on medicines, she's post-PTCA, she's on multiple medicines for cardiovascular benefits. She's got previously a hip fracture 3 years back, and now she can move around in the house, but not to an extent that she's very comfortable with. No definite hypoglycemias, but occasionally mild tiredness around the pre-lunch period. So you can see the glucose control. She's BMI is 20, EGFR is around 45, A1C is around 6.6%. So question is whether you really want to de-escalate a treatment for this particular individual. So if you go through the guidelines of glycemic control targets in older adults, they generally classify older adults into healthy individuals, people with complex or intermediate issues, and people with very complex or poor health. So you can see that there is a different goal for each of these people. And the goal for this patient, particular lady, you could consider it as around less than 8%, but she's at say around 6.6%. And she's experiencing something very similar to hypoglycemias around lunchtime. She's on glimepiride, 4 milligram per day. So I would personally consider that this is an indication, and she's already had a fall, had a fracture. So this is an indication to de-escalate therapy in this particular patient. Again, this is a very personalized decision. You may or may not want to de-escalate therapy. And even in older adults, there is a time in range which is defined as more than 50% rather than more than 70% in normal people, normal type 2 diabetes. There are studies to show that severe hypoglycemia is increased in elderly people who are exposed to sulfonylurea. So this is a data set to show you 75, 80 and 85-year-old, and you can see that as the age of the person increases, the risk of hypoglycemia keeps on increasing when you are using sulfonylureas or insulin. So this is one case of de-escalation of SUs in people with suspected hypoglycemia, an elderly patient. Now coming, whether you want to change from a more intensive to a less intensive regime. So this is a 48-year-old gentleman with type 2 diabetes for 8 years. Over 5 years, he's progressed from basal insulin to a basal bolus insulin. His doctor has been following guidelines to the T. So you can see he's already on aspart 3 times daily and glargine once daily. He's a person who travels, goes to work, traveling multiple times in a month. So he keeps missing the lunch doses and occasionally the dinner doses when he's eating outside. He's got the stress of missed doses and problems with storage of insulin while traveling. There's no hypoglycemia, glucose control is not good. A1C is around 9.6%. And he's got challenges in following a basal bolus regime because he cannot monitor that frequently. So what is the options? He could change to a co-formulation. He could use a GLP-1 RA. He could consider oral agents and basal insulin. So these are easier regimes for this patient to move on to compared to the basal bolus insulin. I'll just show you some data. Idagasp is Rysodec that we use. So a study which looks at basal insulin, basal bolus versus a co-formulation has shown that even the co-formulation is able to achieve with twice daily dosing almost the same A1C as a basal bolus. So instead of 4 injections, you can move on to 2 injections, maybe a bit more expensive than the 4 injections, but reaches almost the same glucose control with a lesser risk of hypoglycemia. So this is an interesting regime for someone who is on basal bolus with type 2 diabetes. Similarly, there is this study with once weekly subcutaneous semaglutide. This has not been published, but it's been presented 1 year back. So basically, people who are on basal bolus insulin has been transitioned to injectable semaglutide once weekly. So see the dramatic change from a 4 injection regime per day to a once weekly 1 injection regime. And you can see the dramatic improvements in A1C which is happening, the dramatic changes in weight which is happening. So these are easier regimes, definitely more costlier regimes, but these are easier regimes to use. Now, you could also, there are studies to support, these are not very big studies, but studies to support that you could consider moving from a basal bolus regime to a basal insulin with GLP-1 with multiple other drugs like an SGLT2 inhibitor, almost reaching the same level of A1C. So convenience in terms of moving from 4 injections to 2 injections to 1 injection, once weekly injections, these are all de-escalating regimes that you can use in practice. Now coming to the third case, this is a person who has been followed for 20 years with type 2 diabetes. Her current age is around 74 years. Her glycemic control has been steadily maintained by a doctor with slowly increasing dose of drugs. You can see she's on metformin, sitagliptin and empagliflozin now. A1C is around 7.2, fasting glucose is around 142, creatinine is 1.8, EGFR is 29. This is the way in which her EGFR has been behaving. The red line is the EGFR. And now over a period of many years, she's moved on to a level where her EGFR is only 29. And what do we do with the medicines that she has got? So these are the metformin guidelines, metformin modifications according to EGFR. And we know that when the EGFR reaches less than 30, especially in an older individual, it's not preferable to continue metformin. So most of the time when we just look at the creatinine, in fact the lower line is the creatinine which you can't compare in this graph because it's all in 0 to 10 starting from below. So creatinine would have progressed from 1.2 to 1.8, but you can see the dramatic drop in EGFR which has happened when you calculate it. So metformin possibly is not a right drug for this patient at this point of time. What do you do with the DPP-4 inhibitors? Most of the time we keep on continuing the same DPP-4 inhibitors, but we should realize that except for linagliptin, all DPP-4 inhibitors have a dose adjustment that needs to be done as the EGFR comes down. And what do you do with the SGLT inhibitors? You can keep on continuing SGLT inhibitors for a longer period of time up to an EGFR of less than 15, or if the patient requires a renal replacement therapy. So you don't need to withdraw this thing. You could possibly consider using a GLP-1 or some other medicine for this patient for glucose control, or even you can reduce the tightening of the glucose control that you are having now. Now this is the next case. It's a 56-year-old gentleman, recent hospitalization for myocardial infarction, undergone PCI, found to have high blood glucose during hospitalization, started on a basal bolus regime. The appropriate regime, just like Vagesh has told, after the surgery you move on to a discharge planning. Most of the time the patient goes on a basal bolus regime. Glucose is excellently controlled. Cardiology is following up the person in the OPD. A1C is 6.8. So at the onset, you can realize that there's nothing needs to be done for this person. He's very well controlled, no hypoglycemia, A1C is perfect. He's on basal bolus regime. He's not complaining about anything. But should we do something for this person? We now have strong evidence like from EMBARRAGE outcome study with empagliflozin or the leader with GLP-1 liraglutide, that these drugs beyond glycemic control have dramatic effects in terms of reducing cardiovascular risk and mortality. And so you should be considering the use of this group of drugs, even though the A1Cs are well controlled. You can use an SGLT2 inhibitor alone with metformin, or you can use a GLP-1 according to your preference. So similar scenarios do happen in all different other conditions, like a person who is started on insulin for a foot infection or a pneumonia getting admitted and then getting discharged. He would have been well controlled on an oral hypoglycemic agent before getting admitted. You can, once the patient gets discharged after 2 to 4 weeks, you can consider going back to the old regime. Or someone who comes with an A1C of 9 or 10% with an osmotic symptoms and type 2 diabetes to outpatient department, you start on insulin, bring him under control, but then sometimes the insulin keeps on getting continued. You could consider stopping it and moving on to a easier regime. So this again a data to show similar data that when you use Soliqua, that is Iglar Lixi, versus a basal bolus regime, be it A1C, be it weight gain, be it hypoglycemia, everywhere a co-formulation like Iglar Lixi is better than that of a basal bolus regime. So this is a CGMS data again to show you that a fixed drug combination like Zultopi does better in terms of glucose variability in compared to a basal bolus regime where you can see the short-acting insulin problems coming up again and again. Now coming to the, I think this is the last case, 46-year-old gentleman with type 2 diabetes. BMI is 28, metformin, sitagliptin, glimepiride, A1C is around 8.6. So he decided to go to a low-carb diet, or just like Umesh has told, decided to go to a intermittent fasting or something like that. So he goes to a commercial program. They put him on 800-calorie diet under this program. 6 days after starting the program, he has hypoglycemic episodes. He consulted his regular physician who reduced his medicines. Now, you would have seen this happening many times because we see it very common because someone would go online, join an online program. Whoever is running the program may or may not be a doctor. So they are at least concerned about the other drugs which the patients are taking. So he goes into a program where he loses weight, reduces his A1C, but starts experiencing hypoglycemia because of the original medicines that he was taking. Now this is a that's a diabetes remission data from the direct trial to show that if you lose more than 15 kgs of weight, you would result in diabetes remission in around 86% in 1 year. So that's a dramatic number of patients who can stop medicines with a diabetes remission program, which properly done under a guidance. So these are patients who would not need these medicines anymore, or who would need minimum medicines, which you need to bring down. And this is data, the same direct trial again, data to show that the use of proportion of glucose lowering medicine year upon year is less in patients who have been always in remission throughout the trial. Now, but this is not a reason why you should stop checking the patient. Monitoring the patient is very important for total diet replacement regimes that you go. So what this is only one trial protocol which I am just showing you. What they do is they stop all the medicines when you start total diet replacement. That is what the trials do. And they keep glucose monitoring to make sure the patient does not go into hyperglycemia or ketosis. And they restart the medicine if the patient goes into a hyperglycemic phase. So it's always important that anyone going into a diabetes remission program, if you are doing it or someone else is doing it, need to monitor glucose and take appropriate action. Now, how do you implement de-escalation? There is a lot of de-escalation protocols which are given for other drugs other than diabetes drugs, because for diabetes, it is a very sort of personalized decision that you do for an individual patient. So identify if the person is the right patient for de-escalation therapy, especially when the glucose control is excellent. Then changing a drug in a patient who's got an excellent diabetes control is a big challenge. So you need to discuss with the patient why the drugs need to be changed, de-escalation. Discuss regarding the risk and benefits of de-escalation, because sometimes when you reduce the drug, the glucose may go up and the patient may again start finding fault with you. Why did you change a regime which was working perfectly? Make a rational plan on how you are going to do that. Monitor the patient, follow up, make changes, or you can even go back to your original regime if things don't work out.